Hi, everybody. I hope everything is good and we can do our session today in a fantastic way. My big honor and pleasure is to welcome and present to you Dr. Professor Kristin A. Madenci. She is a great surgeon and professor of Division of Trauma, Burn and Surgical Care at Brigham and Women's Hospital, Harvard Medical School, with a great experience and a global health. Welcome, Professor Kristin Madenci. We are very much happy to listen to your presentation.
Thank you so much for that introduction. So like Dr. Shabat said, I'm Kristin Madenci. I work at the Brigham. I'm one of the acute care surgeons here. And the majority of our practice here is acute surgery, not as much trauma. And so I'm really thankful for the opportunity to share with you today. Please stop me at any moment for questions. We'll definitely have time at the end, but I also want to make sure that if you think of a question along the way, I'm happy to answer them. All right, so let's get going. I'm going to start quickly talk about the broad differential for acute abdomen, but then I'm going to spend the majority of the time focused on the surgical approach to perforated and bleeding peptic ulcers, perforated diverticulitis, and then end with appendicitis. So the term acute abdomen refers to the development of acute sudden abdominal pain. Approximately 7 to 10% of all emergency visits attributed to abdominal pain. This term is often incorrectly used synonymously with peritonitis. And similarly, the term is also frequently used to describe like an acute surgical problem. However, there are also non-surgical causes in an acute abdomen that we have to be mindful of. As we all know, the mainstay for diagnosis of patients with severe abdominal pain remains a really good history and physical exam. A good history can narrow that broad differential associated with abdominal pain to a few pathologies, and then imaging can assist in rapidly diagnosing this. So just quickly to go through some of the non-surgical causes of the acute abdomen, we have to remember that endocrine and metabolic causes, such as Addison crisis, diabetes crisis, hematologic like sickle cell, and then toxins and drugs as well. For surgical causes, these can be broken down into 5 categories: hemorrhage, infection, ischemia, obstruction, and perforation. So as far as workup, the history and physical often allows us to narrow our diagnosis considerably, and recognizing patterns of certain diseases can help further. Given that surgical training is essentially made up of differentiating these different causes of abdominal pain, I'm not going to labor at this much more, and instead focus on those 3 diseases. So let's start with perforated and bleeding peptic ulcers. Peptic ulcer disease is really common. Lifetime prevalence in the general population is between 5 and 10%. With the development of antacids and the recognition of treatment of H. pylori, there has been a reduction in the amount of hospitalizations and mortality associated with this. The pathology was traditionally related just to hypersecretory acid. And however, with an increasing incidence of H. pylori, use of nonsteroidals, and then also an increase in smoking and alcohol, it really has changed the epidemiology of this disease. So where does surgery come in? Usually we see these patients due to their complications of peptic ulcer disease, which occur in about 10 to 20% of patients. And this includes bleeding, perforation, and then gastric outlet obstruction. Before I continue, I just want to pass along a few great resources for this topic. The World Journal of Emergency Surgery has this great review article that's like full of panelists who put together recommendations specific for this. It's free, open access. And then in addition, SAGES, which is our Society of American GI and Endoscopic Surgeons, has this free online lecture series that discusses the scope of the disease, as well as endoscopic management, and then laparoscopic management for both elective and emergent peptic ulcer disease. It's on YouTube, but I just put up a QR code to hopefully make that easier for you all. All right, so the reported annual incidence of perforations is small. It's 0.004 to 0.01%. but the mortality is significant. So 24% of patients who have a perforated ulcer will die. So although the perforation is less common than bleeding, which we see more frequently, it definitely has a significant morbidity and mortality associated with it. So these patients usually present with acute abdominal pain, pneumoperitoneum, and then local or generalized peritonitis. Interestingly, though, a third of these patients do have a contained leak upon presentation, and so they may not have free air on imaging or peritonitis. As far as where these ulcers are when you get into the OR, most common is along the lesser curvature. Then the least common is on the upper, more cephalad aspect of the lesser curvature. For workup, these patients typically have a white count, an elevated amylase, and then a metabolic acidosis upon presentation. CT obviously is going to be your best imaging choice for diagnosis, but if you have a patient who comes in, they're in septic shock, and you have a very high suspicion that this is a perforated ulcer, you can just get an x-ray. An upright abdomen, even a left lateral decubitus could also show you some free air in the belly. Granted, most of these patients are in so much pain, they wouldn't be able to tolerate that, but it is possible. And having free air and a suspicion for perforation, an unstable patient is enough. You can just take them to the OR. Otherwise, we tend to get a CT scan. In a patient who is more stable, but you still have a high suspicion and CT is not showing any free air, you can do an upper GI with contrast. This can be helpful to catch those small leaks that really haven't formed yet. Okay, so who goes to the OR? Almost everybody with a perforation. You have an unstable, sick patient, you go to the OR. You have a stable patient who has peritonitis, you go to the OR. You have a patient who has an acute perforation confirmed on CT, their best outcome is if you take them to the operating room. The patients who you may not run off to the OR are those who have multiple comorbidities, very old, frail, who are not going to be able to withstand any operation. These patients who have a high morbidity and mortality, it's important to have that goals of care discussion. Likely the patient's going to be pretty out of it, but to have that with the family to let them understand what this is actually going to look like, because those patients will probably be admitted for a long period of time, months in the hospital, going to a rehab center afterwards, have multiple operations, etc. And then there is a group of patients you have to be very highly selective with who have a sealed perforation upon admission. And as long as you get that upper GI and it doesn't show an active leak, you can manage these patients non-operatively, at least initially, as long as they continue to go well. All right, so there are some prerequisites and components for non-operative management. And I want you to think about the list of R's. This shows no radiological leak. You're able to perform serial exams and labs on these patients. They do not have multi-organ failure, so they're not going into respiratory failure, renal failure. They're in a place where you can admit them and you can follow them with serial exams, serial labs. And then they're also in a location where at 2 in the morning, if they become sick, someone's going to be able to operate on them. So it's a very strict prerequisite, a group of patients who you can think about non-operative management for them. A multivariate analysis was done that did find a couple factors that are associated with failure of non-operative management. This includes the size of the pneumoperitoneum, so a significant pneumoperitoneum, they're likely not going to make it through with just non-operative management. Patients who present with tachycardia, and then interestingly also distended bowel loops on imaging. There are numerous scoring systems exist. The Bow score has been well validated to predict mortality and morbidity in patients with a perforated ulcer. It includes four risk factors. 1, severe medical illness. If they present with preoperative shock. If the duration of perforation is presumed to be longer than 24 hours. And then, so the score then is, if they have one of those, their risk of morbidity is 47%, sorry. 2 of those, 75%, and then 3, 77%. So as you can see, this is a very morbid procedure, and it is something to discuss at length with families preoperatively. Some other factors that are associated with poor prognosis include those factors that we commonly think about. So older patients, patients who have multiple comorbidities, those again who are unstable upon admission, those who are acidotic, tachycardic, and then in any evidence of renal failure, low albumin, and then again if they've had any delay in their operation. So these patients, if they're not in septic shock upon presentation, they will be shortly. So you want to follow surviving sepsis guidelines, meaning rapid fluid resuscitation and initiation of antibiotics. Mortality is reduced if fluids are initiated within 1 hour, and 1 hour can happen very quickly when you see a patient in the ED. So it's very important that those fluids are hung right away. End targets for resuscitation include hemodynamic stability, normalization of lactate, and then adequate urine output. There was a Danish study that found that every hour of surgical delay in patients once admitted with a perforated ulcer was associated with a 2.4% decrease in survival. So that means that in 2 hours, you're already at 5% decrease in survival compared to where you were 2 hours ago. So these patients need to go to the OR without any delay. And just a note on the utility of antifungals, as traditionally patients were put on antifungals and antibiotics for gastric perforations. Really, antifungals should be reserved for those patients who are immunocompromised, advanced stage, so over 80, multiple comorbidities, or those who have already had a prolonged ICU stay. So they're going to be at increased risk for a fungal infection. So once you know you're going to the OR, you then need to decide on your approach. Are you going to do this open or are you going to do it lap? The literature shows that the outcomes are comparable. However, you also have to consider the stability of the patient. A really sick patient is not going to withstand you insufflating their belly. You're going to have to go open. If you have a patient with peritonitis, but they're hemodynamically stable, then you can perform a laparoscopy for this type of disease. Once you're in the OR, your goals are to get source control, number one, get tissue so that you know what you're dealing with, and then ulcer management, addressing the actual problem, and then considering whether or not you're going to do any type of feeding access for the post-operative, and then whether or not you're going to keep the patient open or closed. And so we're just going to go through these systematically. Getting in, so you can go laparoscopic versus open. Again, unstable, you're going open. You're going to do an upper midline incision. For laparoscopy, we typically do a Hassan technique, so getting in open at the umbilicus. You're going to place 2 working ports in the mid-abdomen, right and left, and then you're going to need a liver retractor. So you're going to put one in the epigastric as well to retract the liver. Once you're in, you're first just going to wash out the patient. Sometimes this alone can drastically improve the hemodynamics of the patient. And we recommend like a ridiculous amount of irrigation. So like 5 to 10 liters, not just a couple buckets. This is like 20 buckets of irrigation to really clean it out as well as you can. Then you're going to find the perforation and send tissue. It is very easy to forget this, and then you never can get it back. So you really want to send a little piece of that ulcer, and so you have a better idea of what's actually causing this. For how you're going to manage this ulcer, it depends on the size and the tissue that is surrounding the hole. So if the hole is small, like less than 2 centimeters, the tissue is healthy, you can usually close these primarily. And this would involve interrupted silk or vicryl, which is shown in that picture A. Multiple studies have shown that a patch over repair, like shown in B, actually doesn't improve outcomes, and laparoscopically, it adds a significant amount of time to the operation. At the same time, I would say that most of us do it still, just because it feels like, you know, okay, we're going to do one more thing to make sure this thing holds. So I just to tell you what the literature says, but I would say that most of my colleagues here would still put over a flap if you repair it primarily. So ulcers greater than 2 centimeters require more of a tailored approach, and you should have in the back of your mind that this could be a malignancy. About 10 to 16% of all gastric perforations are caused by gastric carcinoma. If this is the case, if you suspect malignancy, if you look at it, if you send it and it actually comes back in time frozen and you know it is, then you're going to do a resection. You can do a gastric wedge resection if it's a small tumor, or if you have to do a bigger gastrectomy, that is something you'd also consider. If you have a low concern for malignancy, but the tissue is still friable, then you're going to want to do a patch. And the traditional Graham patch, which is shown at number 1, involves placing sutures with long tails through the ulcer, and then you pull up a tongue of momentum, and you want to keep it attached to its blood supply. You're going to lay it over that hole, tuck it into the perforation, and then you're going to tie down those strings over that omental patch. It's important not to strangulate it, though. You want to keep that omentum alive. So let's say you can't completely put your sutures all the way through both ends of the ulcer. The other option is number 2, where you still pull up omentum and you kind of tack it down circumferentially around the hole. And then the third option is a completely free omental patch. And what this means is that you actually just take off a part of the omentum and you slap it on over that hole and suture it down. It doesn't have a blood supply, so that's the major difference. In cases when you don't have enough omentum, so sometimes in really elderly people who are really frail and skinny, they have no intra-abdominal fat, or if they've already had a surgery where they've used the omentum for something else, you can also use the falciform, and the falciform is right there. So you just take it down and you flop that over that hole. If neither the omentum or the falci is available, then you can also consider a small bowel serosal patch. So that is grabbing bowel anywhere really in the belly, distal to the LOT, 20 to 30 centimeters, pulling it up, and you're not making an anastomosis. You're really just patching the serosa to that hole. So what about duodenal perforation? Because that was mainly, those were gastric perforations. Most perforations of the duo are located anteriorly in the first portion of the duo, and they're immediately distal to the pylorus, and they're small, about 5 millimeters. For these small perforations, you can do that simple interrupted repair is usually sufficient. For larger holes, a more complex approach is generally needed and depends on the proximity to the ampulla and as well as the stability of the patient. So let's go through that. If amendable, a Graham patch is a great option for this. This is what I just described. You do those interrupted long sutures, you take the omentum, you patch it, you tie it down, and then you plug the hole. If you don't have enough omentum, you can't use the falci, you can again use a serosal patch, which is similar to what I just described. Another option is to perform a Roux-en-Y duodenojejunectomy. This is typically if patients, you've initially washed them out and you're taking them back when they're more stable. You go, because you don't want to do such a big operation at that initial index case. 20 to 30 centimeters distal to the ligament of Treitz, you're going to pull up some jejunum and you're actually going to do an anastomosis. 2 layers, and this is for perforations that are massive, greater than 1/3 circumference, and a serosal patch would just like narrow the lumen. So instead you do this. Finally, another option is a pyloric exclusion with the creation of a gastrojejunostomy. This is truly one of the last resorts for these large ulcers, and this would be if there's severe tissue inflammation and mobilization of the duo is just not possible. This should be reserved for major blowouts like you see with a trauma patient who's lost greater than 2/3 of the wall of the duodenum. For the pyloric exclusion part, historically, you would make a gastrotomy and then suture the pylorus. A fast way to do this is to just take like a TA stapler and you staple across the pylorus. You just don't cut it. So you leave it in continuity, but you've closed off entry into the duodenum. Once you do that, you do what you can with your huge hole in the duo, placing a Maladcott drain in there and trying to suture around the drain that you're going to pull through the skin. That is, the point of that is that you're trying to create a controlled fistula. And then you need to figure out how you're going to have, where's your diversion? So your diversion is going to be a gastrojejunostomy, and then you're going to pull up your limb to perform that anastomosis. And then finally, your bailout procedure is just drains. So let's say you have an incredibly sick patient, you go in there and they've probably perforated a long time ago, the abdomen's frozen and you're not really able to do anything. If you can place a tube into, like a Maladcott, into that perforation and try to suture it down, great. If you can't, just stick it in there or around there. Then you want to have drains in the right upper quadrant, left upper quadrant. If you can do behind the duo as well, that's great. And then there have been cases described using this retrograde duodenostomy. I haven't seen it work really well. And what this is, the picture on the right, where you basically have two tubes coming from the jejunum. One, you try to milk backwards towards wherever the duo is injured, and then one is the feeding J. So this is, again, this is last resort. You have no other options. So after you've addressed the ulcer, you wash them out, you need to consider whether or not this patient needs long-term feeding access. For healthy patients who have a small perforation that you're easily able to repair, we typically don't place any feeding access. But most patients that we see, at least, are sick and old and have multiple comorbidities. So we always figure out how we're going to feed them after the case. You can either just place a Dopphoff or a feeding tube past your repair or anastomosis, or you can consider pulling up a jejunostomy. You also want to make sure when you leave the OR that these patients' stomach are decompressed. So placing it in a G tube or a G tube. And then your last decision is whether or not you're going to close the abdomen. And this depends on the stability of the patient as well as the degree of contamination. Patients in septic shock with severe physiologic derangement should undergo a damage control surgery. You leave them open. We tend to leave patients open fairly frequently if there is gross contamination. And this is in order to keep washing them out. So you wash them out the first time, you keep them open, you take them back to the ICU, you resuscitate them, you give them lots of fluid, you give them their antibiotics. And then once they're down on their pressors, that's when you take them back to the OR again, you wash them out again, and then you either address your ulcer further, put them back together if they're in discontinuity, and then close them at that time. So post-op care, you continue antibiotics for at least 4 days, depending on their comorbidities. You're going to follow up the culture data, pathology, and then also make sure you're treating for H. pylori if that's on your differential for etiology, and decide whether or not you want to get an upper GI during their postoperative course before feeding them further. Okay, that was perforated ulcers. Any questions or anything to talk about at this point, or you want me to keep going? Oh, I see some questions. Go ahead.
Dr. Nozdrin, please.
Yeah, just have a few about the perforation. Thanks for the great beginning. About damage control, do you try to drain the biliary tract, or you just leave them?
Leave it. Within 24 to 48 hours is fine. And you might see their T-bilies and direct bilies go up, but it's not going to make a difference. So I typically don't. If I'm really worried about the biliary tract, then I would stick like a pediatric feeding tube through the ampulla. And you can actually just leave it draining into the small bowel, or you can pull it out as well.
Okay, and if it's possible for the second one, what about the difficult stump? If you proceed to the resection of the stomach and you have a difficult duodenum stump, do you have any tips and tricks on that?
Yeah, so the Maladcott drain is really helpful. sticking a malacot even into a duodenal stump can help release some of that pressure so that you don't have a stump blowout. At the same time, it's pretty common that if you're going to do an antrectomy, which I didn't go into the greater details of that, of having a stump leak, and so just leaving as many drains as possible. The retrograde duodenostomy can also help with that. So what that is you put that tube distal to your repair and then thread it backwards towards your repair and pull it out through the skin. That is another option to try to decrease that pressure in that limb.
Okay, thanks.
Of course.
We have
Okay. Dr. Mikhailuk, please.
If we already made duodenostomy, when we're going to remove this in postoperative period?
Months. So you keep that in and you allow a fistula to form. So it's usually at least 8 to 12 weeks before you even consider taking it out. You can do a drain study. So you stick contrast down that duodenostomy and make sure that you don't have extravasation. So if you have contrast that goes everywhere, then it hasn't really healed around that tube. As long as the contrast goes right into the bowel, then you know that a tract has probably formed and you can take it out.
Thank you.
Good questions.
Dr. Червонооченко.
Excuse me if this was highlighted before, I wasn't present at the beginning. What are your thoughts on laparoscopic approach to perforated ulcer repair?
Yep, I think it's totally appropriate in the patient that's stable. So if they're unstable and crashing, you just don't have time for that. But in a stable patient who has peritonitis and free air, then doing laparoscopic can be beautiful, and it actually can be easier to see everything. So I think it's absolutely fine.
Thank you.
Mm-hmm.
Dr. Lesecka, please.
Thank you so much for a great practical lecture. And my question is, how do you manage a patient with combined perforation of anterior and posterior wall if it's unstable?
Yes. So that would be a for sure damage control. I would just wash them out. And you wash them out, you don't even have to deal with the actual perforation until the take back if they're unstable. If they're stable, then you have your 2 holes, right?
Yes.
And then you have to decide if it's resectable or not. If it's in the stomach, then you're doing your antrectomy, which is normally where that is, right? Where you have the anterior and posterior. Then you're going to do that antrectomy, that distal gastrectomy, and do a Billroth 2, which is the gastrojejunostomy, not putting the duo together with the stomach.
And any idea nutrition, or is endoscopic nutrition for patient?
So in that patient, I would do a J-tube.
Thank you so much.
With that new GJ, those patients always have so much reflux and they take a long time to heal. So I would do a J-tube if I have to do a Billroth 2.
Thank you.
Of course. All right, one more and then we'll
Okay.
keep going. What do you think?
Yeah, Dr. Boyarsky.
Thank you for the great lecture. My question is about, in the case if it's the tumor, what types of surgery do you perform? And I think no lymphodissection. Yes.
Right. So in this case, if you have a stable patient and if you have oncology available, then you're going to call them in. So that's an easy answer, right? In the unstable patient, you want to have at least 5 centimeter margins for most cancers. So that's what I would do. I would just make sure I had circumferentially 5 centimeters. I wouldn't do the lymph node dissection because you're not going to be able to do a full one quickly, but I would take as much momentum as I could.
Thank you very much. Maybe we can continue.
All right,
Are you
sounds good.
okay? Thank you.
So the next major complication of peptic ulcer disease is bleeding. These patients are usually managed endoscopically as the first line, and then angioembolization should be the second line. Even in a patient who, let's say they're treated endoscopically, then they're treated angio, they should have another endoscopic attempt before you operate. These are patients you do not want to operate in and on unless you absolutely have to. Endoscopic is diagnostic and therapeutic almost 90% of the time. They have so many options. They can clip, cauterize, epi injections, and only once they've failed multiple endoscopic interventions should you really be taking these people to the operating room. Now, sometimes the endoscopists and GI folks are a little nervous to take these patients or to deal with these patients who may be bleeding fairly profusely. So one thing we do fairly often is that we book the case in the OR and the endoscopist comes down and they actually do their procedure in the OR. That way they feel safe. Like, okay, if this ends up going poorly, the surgeons are here and they can take over. And often that has worked very well for us. All right. So next, you're treating these patients very similar to any trauma hemorrhaging patient. Rapid evaluation, large bore IVs, type and cross. These patients are getting an upper midline incision. You're not doing this or even considering to attempt this laparoscopically. You make a generous midline incision. For gastric bleeding, the easiest thing to do is to resect it. The thing is that you need to know where you're resecting, and sometimes that's not as easy as it sounds. And so if you're able to be a part of the endoscopy prior to meeting the patient, then great, then you can see where the problem is. If you're not, then have a scope in the OR so that someone can be scoping as you're opening the belly so you can figure out where you're going to be resecting. If resection is not an option for whatever reason, you can try to oversew these as well. Did I hit everything? Yeah. Okay. So duo bleeds are a different beast. And these have a significantly higher mortality and reoperation rate. So it's really important to understand the anatomy of bleeding. And as we are traditionally taught, duo bleeds are typically from the gastroduodenal artery. This is the artery that comes off the common hepatic, as you can see in this left-hand picture. And then right behind the duo, it splits. And so you have a trifurcation, and that is usually where the bleed is. And so when you're going in to suture off this bleed, you have to at least tie off 3 vessels. And that's the common mistake. You get 1, you get 2, and you miss the 3rd. And then that patient's going to go back to the ICU or wherever, and they're going to bleed again. So how do you make sure you've hit all 3? 1, when you make your incision, you make it big. You're going to close it, so it's fine. So make a long longitudinal incision over the pylorus. You're going to flay open that duo, and you're just going to see blood, right? So what you can do is you do a coker, you take down the attachments laterally, and you stick your finger and try to compress the ulcer with your thumb and your finger like this. That at least will slow things down for someone to be able to help you with suction. And then you're going to start throwing your sutures. Like I said, you're placing 3, 1 superiorly, 1 inferiorly. And then, can you guys see my arrow or no? Can you see this?
Yes.
Yes.
Yeah. Okay. Okay. So this vessel is the one that is hard to get, and it's a U stitch. So you have to, as shown in this picture, you have to go down. You're going to come out, and then you're going to go down again to make sure that you really have encircled this inferior feeding vessel of the GDA. All right. When you're closing this incision, no matter how big you've made it, you still want to close opposite of your longitudinal. So you close transversely. You're going to do 2 layers as well. And this is to make sure that you're not narrowing the lumen and that you're also not hitting the ampulla. Okay, so that includes peptic ulcers and bleeding ulcers. Any questions about bleeding peptic ulcers? Yes, Dr. Nozdrin.
Dr. Nozdrin, please.
Thank you.
Yes. And so if I'm understand you correct, so you do the duodenectomy and then the suture the 3 vessels.
Yes.
Is it possible just to ligate the GDA after it comes from the hepatic one?
Common hepatic. So if you hit that one, you're still going to have the 2 below that are going to continue to bleed.
Okay.
because of the anatomy. So yes, you could ligate that and it'll slow it down, but it will not stop the bleeding. And also these, it's bleeding because you have an ulcer with significant inflammation. And so often the duo is like caked down. And so it's very hard to actually get to the origin of the GDA.
Okay.
So it's a good question though.
Dr. Червонооченко, please.
In case of such a ligation, don't you have a risk for duodenal ischemia and potential necrosis?
So theoretically, yes, theoretically you would think that, but there is so much dual blood supply to the stomach and to the duo that I've never seen an ischemic duo from tying off a duo ulcer.
Thank you.
Mm-hmm.
Dr. Ismailov.
I have a question about bleeding, gastrojejunal anastomosis, and also bleeding ulcer of jejunal anastomosis. What can we do about it? Because we recently had a patient like that, and we transfused like probably 20 units of blood over 3 days, and luckily he has survived, but we were like helpless.
Yeah. So that's bleeding from like a marginal ulcer, right? That's what it's called, that gastrojejunectomy. And we typically do the same thing as what you just described. You just transfuse and transfuse and transfuse. Trying medical therapy as well, so Carafate. And I know it sounds like that's really what we're going to recommend, but honestly, we try not to operate until the last second as well. If you do end up having to operate, you would open up that anastomosis and oversew it. So you're not going to resect, right? Because you don't have that much to resect. You're just gonna make an enterotomy and then oversew that ulcer.
All right. Thank you.
And now, if you're really slick endoscopically, our minimally invasive surgeons would try to do that endoscopically. Laparoscopically. Sorry, laparoscopically.
What about angioembolization?
Angioembolization we typically don't do that for a marginal ulcer because you don't want to kill off the blood supply to the anastomosis.
Thank you.
You're welcome.
And I saw before Dr. Simora. Do you still have a question? Dr. Simora? Dr. Tatiana Simora?
No?
Okay, maybe.
All right, no problem. If you think of more questions though, anytime. Okay, so we will move on. Perforated diverticulitis. For this topic, the American Society of Colon and Rectal Surgeons put out a clinical practice guidelines for the treatment of left-sided diverticulitis, and this was updated in 2020. And there also are 2020 guidelines from the World Journal of Emergency Surgery that are great. This is a QR code to a SAGE's video describing damage control operation for diverticulitis. Prevalence of diverticular disease has risen steadily over the past decade. Recent evidence suggests a lifetime risk of 4% of diverticulitis amongst those who have diverticulosis. Most patients, as we all know, who develop diverticulitis, we can just treat with IV antibiotics and we're done. 15 to 32% of patients, which is a third of patients basically that are hospitalized with diverticulitis, may require an emergency operation throughout their stay. So which patients for these perforated diverticulitis are we operating on? Patients who are unstable from the perforation, or those who have significant peritonitis on exam from their contamination. The Hinchey classification system has traditionally been used to describe the extent of peritoneal contamination. So a stage 1 is the picture in the top left. That's a pericolic or mesenteric abscess. Stage 2 is a walled off abscess that extends into the pelvis. Stage 3 is generalized purulent peritonitis. And then stage 4 is generalized feculent peritonitis. In general, the majority of microperforations, which are not even included in the Hinchey classification system, as well as Hinchey 1 and 2, can be managed non-operatively with antibiotics and interventional radiology. Most Hinchey stage 3 and stage 4 perforations do require surgical intervention. Some of these are managed initially non-op when they're stable and they just have mild local peritonitis, but then they do end up requiring operation either during that admission because they've failed to improve or electively as an outpatient. So what I'm going to discuss though is more the diverticulitis patient who requires an emergent operation. The indications for this include those with a free frank perforation with a significant amount of free air, the unstable patient, and then those who are ill appearing with organ failure from their peritonitis. Overall mortality following emergent colectomy for diverticulitis is 5%. Some of the predictors of mortality include those that are older, have a high ASA class, elevated creatinine, low albumin, and then if they have 2, 3, or 4 of these predictors, the mortality significantly increases to 10, 23, and 54% respectively. So the goal of the operation in emergent perforated diverticulitis is source control. The second goal is to restore intestinal continuity. So for patients who are going urgently and emergently to the operating room, if they are unstable, they should be getting an open operation with consideration of damage control. So what do I mean by damage control? Washing them out, resecting, and then placing a temporary abdominal closure and allowing time for resuscitation. Laparoscopy is definitely an option for patients going to the OR for perforated diverticulitis, but only if they're hemodynamically stable and not showing evidence of organ failure. The most recent guidelines from the American Society of Colorectal Surgeons suggest that resection of the entire sigmoid colon down to the rectum with anastomosis and plus or minus proximal diversion is the operation of choice. Now, this is a change from previous recommendations. Historically, the recommendation was to perform a Hartmann's, so just pulling up a colostomy in essentially all emergent cases for perforated diverticulitis. There was a colon perfect trial as well as a diverti trial that looked at randomly randomized patients with Hinchey stage 3 and stage 4 who underwent emergency surgery. They were randomized to either a Hartmann's or to a primary anastomosis with a DLI, and there was no difference in overall morbidity and mortality. Further, complications with stoma reversals were reduced in the DLI group, and long-term stoma-free rates were higher in those who had a diverting ileostomy. Now, what's important to know about this is that this evidence was for patients who are hemodynamically stable, who were not old, so not like 80 years old, and they didn't have multiple comorbidities. All right, so here is just a general algorithm or way to think about these patients. On the left, the hemodynamically stable patient who comes in, who needs an emergent operation, can get what I just talked about, that primary resection, putting them back together, and most likely doing a diverting loop ileostomy. The middle group are those patients who initially are unstable. However, you start to resuscitate them and they're turning around very quickly in the OR, if not preoperatively, after they've gotten their antibiotics and IV fluids. These patients, if they're fairly healthy and you see them doing well postoperatively, you can do the same thing, that primary anastomosis and diversion. Patients who are frail, who have those comorbidities that I just listed, these are the patients that you still should consider doing a Hartmann's to increase their survival. And then finally, on the right-hand side is the unstable patient. These patients, you're doing your damage control. You're getting in, you're washing them out, you resect, and then you fight another day, the rest of the case. So unstable, your focus, like I said, should be on controlling contamination as fast as possible, resecting the sigmoid if you can. For patients with multiple comorbidities, frail, then you consider at this index operation, resecting and performing a Hartmann's. And then last, There's still a group of patients that present with more of an acute on chronic diverticulitis, and I'm sure all of you have seen these cases where you open and the sigmoid is just socked in down to the pelvis and down against the pelvic wall, and you just cannot mobilize. You're not going to be able to, one, take it out safely without nicking a ureter or the iliacs, and so for that patient, they get a Hartman's. As far as technique, I'm going to skip this. This is just like the steps of how to do a sigmoidectomy. I'm sure all of you are very aware. For patients who are stable, who have frank peritonitis, these patients can still tank very quickly, so you do need to get them to the OR quick, but you can do this case laparoscopically with your anastomosis and DLI. Here are the port placements for a lap sigmoid. There are a lot of options. This is just one option. We usually do a hand port in the lower midline, which is really nice and helps you mobilize the splenic flexure in order to be able to pull down your colon for your anastomosis. Some common pitfalls of doing this operation is not taking enough sigmoid. You have to get down to the rectosigmoid junction. If you don't, that patient is going to be at risk of having another episode of diverticulitis. So approximately, you want to take as much colon as you see severe disease, and then distally down to the rectum. Post-operatively, they need a colonoscopy, all these patients, usually at least 3 months out. You have to think about when you're going to reverse them. In most patients, I'll reverse them at 8 weeks. Before that time period, I'll get a barium enema just to make sure my anastomosis looks okay, there isn't a stricture, that it's not still leaking. Okay, that's it for perforated diverticulitis. Questions about that section, and then we're almost done. Yes. Dr. Shabbat, I'll let you choose. You did a good job.
Yeah. Dr. Boyarsky, please.
In the case of primary anastomosis, will you use protective
I usually
stoma?
I do
or
almost
no?
every time. I don't do a colostomy though. I do a loop ileostomy. I feel like obviously an ileostomy is a lot easier to take down. It's easier to take care of. The only thing is the higher output, so they can have high ostomy output, and then you're dealing with that. So if the patient's really elderly and I'm worried about that, then I would do a diverting loop colostomy.
Thank you.
Dr. Nozdrin, please.
Yeah, that was my question
Dr.
about
Nozdrin.
that was my question about loop ileostomy or colostomy. What will be your preferred choice? Thanks.
Yeah, my preferred is ileostomy.
Shenko, please.
Did I understand you correctly? If you were saying that in a case of diverticulitis, if you see a diverticular disease along, for example, descending colon or the entire colon, do you remove the entire diverticular part of the colon, even without diverticulitis?
Yeah. No. So I would just take out the more severely diseased segment, which obviously is mainly usually the sigmoid. But as you mentioned, you can have disease that goes through the entire colon, but I wouldn't do a total colectomy. I would still just do where the significant disease is.
Thank you.
Dr. Ismailov, please.
I have a question about anastomosis. So how do you make a decision to put an anastomosis like and just not use like an end colostomy? What are the criteria? Maybe the time that patient has been sick?
Mm-hmm. Yeah. So I really try to do an anastomosis if I can. And because for the reasons that I mentioned before, the morbidity and the mortality is a lot lower. So even patients who have multiple comorbidities, if they're younger than 80 if they're not immunocompromised. So if the patient's on steroids, I'm not going to do it. If the patient's a cancer patient, then I would never do that, right? They are going to get a colostomy. But anyone who doesn't have cancer, who's less than 80 years old, who, when I do my resection, the ends look healthy. If the rest of the colon looks terrible, I'm not going to do the anastomosis, right? You're only going to do it if the tissue truly looks healthy. And then also if they're not acutely ill. I will never put someone together who continues to be in multi-organ failure, who continues to be on pressors in the ICU. So after that damage control procedure, when I go back the second time, if they're off pressors and they're looking good, I'm going to put them together if I can. If they continue to not do well, like on that second take back, if they're still on a little bit of pressors, I'm not going to do it. I'll just pull up an ostomy.
So even in severe peritonitis, you can do a damage control, then take the patient back to the OR and take a second look, right?
And put them back together. Yes. That's what's
Right.
great about a damage control operation, is that you can really wash them out well, resuscitate them, bring them back. And if it looks a lot better, which often it does, then you can do your anastomosis. And then pull up a diverting loop still, right?
Mhm.
Yeah.
Thank you.
Mm-hmm.
Dr. Mikhailuk, please.
What percentage of primary anastomotic leakage do you have in case of hinge tree or fall?
I'm sorry, I couldn't hear the question.
What percentage of anastomotic leakage primarily done in case of hinge tree or hinge fall?
So I usually say 10 to 15%, which is why you do a diverting loop. If you do the diverting loop, then even if you have an anastomotic leak, it doesn't matter, right? So that's why I almost always, I don't think I've ever just put someone together and not done a loop ileostomy.
Thank you.
Dr. Demchuk, please.
Thank you. How do you understand that you need urethral stents in your patient, and if there is any opportunities to make it intraoperatively?
Yeah, that's a great question. In the patients who are unstable, we never put stents in just because it takes so much time. In a patient that's open and you're taking back the second time, then we do have urology put in stents. And then what was the second part of that question? Putting them in intraoperatively?
Yeah, if you have an opportunity to make it intraoperatively.
Yeah, that's fine too. If that's an option for you, that sounds great. Again, it doesn't prevent injury, right? It just sort of makes us feel better that we're able to see it and find them. And so it's kind of like it doesn't actually prevent the complication, but a lot of us still like to have them just to know that they're there.
Thank you.
Mm-hmm.
Dr. Lesecka, please.
In case when you do a resection of injured bowel and do anastomosis and it's not enough hermetic, did you do a protective ileostomy in that case?
Do you do a what?
Protective ileostomy. If
Yeah.
you do a yes.
Yeah. I mean, it's such a the risk is so huge, right? So if you don't do one and you have a major leak, you're setting that patient up for complications and multiple operations. You do the ileostomy, it's such an easy procedure. We usually admit those patients after the ileostomy reversal and they go home the next day. So it's worth it to divert them.
Okay. Dr. Mikhailuk, I think that maybe you can ask through Heal UA platform, because it's already second question. We need to go forward with the next question of the presentation. Thank you.
All right, this will be quick because appendicitis we all know and are probably most familiar with. I'm just hoping to hit a couple key points. So there's uncomplicated, complicated, and obviously is when it's perforated. The timing of surgery, I think this is important. So historically, we have been told you have to operate on these appendicitis patients very quickly. Recent literature has suggested that these patients can wait up to 24 hours without any increase in the risk of perforation. However, delaying these patients more than 48 hours definitely increases their risk of a surgical site infection and other complications. Operative approach, I'm going to skip. Pregnant patients. So these are the ones that kind of make all our hearts beat a little faster when we're in the OR and we know that a patient is pregnant. For the first trimester, your ports can be exactly the same. Don't have to change position. Second trimester, you're going to move your ports all up. So you're going to place your camera port mid-epigastric, and you're going to place your working ports on both sides, right and left. Third trimester, the uterus really kind of pushes the right colon down into the right. And so you're going to make most of your working ports all on that right side in order to more easily mobilize the colon and the cecum. Open appy, here are just the steps if interested. Okay, so what happens when you think you have an appendicitis, you go in there and you find a normal appendix? Something was causing that patient to have pain, right? So in women, it's important that you inspect the ovaries. You're looking for tubo-ovarian abscess, ovarian torsion, maybe an ectopic or a tumor. You want to run the whole small bowel. You're looking for any inflammation of the distal ileum, any Meckel's diverticula. Look at the gallbladder. You're going to look at your colon. And then you may find Crohn's when you get in there. If that's the case, if the appendix looks normal and the base of the appendix is normal, you should take out the appendix because you want to prevent this from happening again. When they start having flares, you want the appendix to be out of the question. What if you go in and you think you found cancer? For an appendectomy for carcinoid is usually enough unless it's at the base, then they need a right hemicolectomy. You're not going to do that in that initial operation. You're going to do your appendix, you're going to send it for pathology, and then the patient's going to have to go back and have their formal resection. Non-operative management, I'm not sure how common this is for you guys. For us, there was a couple years where there was a strong push to do more non-operative management for appendicitis, meaning you do IV antibiotics for 1 to 3 days in-house, and then they go home on oral antibiotics. I want you to look at the disadvantages of this. There is a significantly high risk of failure, 10 to 20% at 30 days, 30 to 40% recurrence of appendicitis at 1 year. So this is something that needs to be a very informed discussion with the patient about what they're getting themselves into if you decide to do non-operative. They're probably going to be readmitted within a year with appendicitis again. So who are the candidates? Patients who are localized, hemodynamically stable, and they don't have an appendicolith. If they have an appendicolith, they're at extremely high risk of having a recurrence. You're not going to do non-op management for any patients who's sick, or if they're pregnant, immunocompromised. And then relative contraindications are the older patients who have any concern for malignancy. Complicated appendicitis, they usually present after like a delayed presentation, fevers, more systemic illness, and are sicker upon presentation. How we treat them, if they're sick and unstable, we tend to take these people. And this has been also a switch in the way that we've been managing our patients, but we found that they're getting in and out of the hospital quicker if we take them when they present. We do the appy, we keep them in a house for a few days with IV antibiotics. For those patients who are stable, fairly similar. If it's a very small abscess, we still take them to the OR and do an appendectomy. If it's a larger abscess, then we do IR drainage with antibiotics. For a phlegmon, if it's just inflammation and you think the colon looks okay on CT, we usually take them to the operating room and do an appendectomy so that it's just over with. If it looks like the cecum is involved and there's like a significant amount of inflammation, then we just do more conservative management of IV antibiotics, wait, and then do an elective appendectomy